I'm pretty sure that number is going to not drop, but it's only going to increase once we have the president of Kasoga speaking to us.
Yes.
Can I request Dr. Kalpana to please introduce our next speaker?
Thank you so much, Pradeep sir, for your wonderful opportunity that has been given to me, and the number of viewers that indicates the credibility of the CME, which you have been organizing. Fetus in Focus. We had wonderful discussion by Mala Srivastava ma'am, and now we have our own ma'am, Vidhya Thobbi ma'am, who is going to talk about fetal neuroprotection. It is my privilege to introduce Vidhya Thobbi ma'am, who is the current president of Kasoga, who is very dynamic over the past few months, and past committee chairperson of Food and Drug Committee. And actually, we are missing you, ma'am. Recently, only I came to know that you couldn't manage to reach Kodaikanal. We have been waiting for you, but we are missing you, ma'am. And madam doesn't need any introduction, but formally, let me introduce ma'am. President Kasoga, 23 to 24, Professor and HOD of Alamin Medical College, Jaipur, Chairperson Food and Drug Committee, 18 to 20, received Best Committee Award for her activities in the FOGSI ICOG Governing Council member, 21 to 23, received FOGSI Champion Award, National Corresponding Editor of JOGI, Organizing Chairperson of various prestigious conferences, Kasoga, 2016, President Bijapur Urdu Society 2009, and she has got various publications to her credit. And she has been invited faculty in various national, international conferences, and advisory faculty of boards, Rajiv Gandhi University of Health Sciences. And Madam has got a very rich experience, teaching experience and clinical experience for the past 30 years. It's our privilege to have you here in this prestigious forum, ma'am. Over to you, ma'am.
Thank you very much, Dr. Kalpana. Really, I'll miss the Vice Presidential Conference. I know that. And I'm extremely thankful to Dr. Prateek. We know how academically he always discusses various problems, and his all talks are evidence-based. So always I remember whenever I talk about Prateek, it is always evidence-based, and I always relish to listen from him as well. And it is always a pleasure when he invites us. So I will be talking today something about the neuroprotection of magnesium sulfate, and this is my screen. And if I am able to share my screen, shall I try, Dr. Prateek? This has been shared by, I think, Shrutika.
No worries, ma'am. Whichever way you're comfortable.
Because once I go on talking, she should change the slides, and every time I should have to tell, no?
Yeah.
Shrutika, please let me share, and then if it is not possible, then you can. Shrutika? Yes.
Can you stop sharing so that madam will try?
Yeah, I will just try. If it is not possible, then many times it is not possible because...
It's done now. Ma'am, you have to make it full screen, that's all.
Yeah. But the above one screen is coming from above. How to make it?
You have to slideshow from beginning. Slideshow.
Yeah, I think she's done from beginning, but unfortunately, I think it's not working.
Okay,
so we'll go back to Shrutika.
Yes, yes.
Yeah. Shrutika,
yes.
please go ahead. Let us continue.
Yes. Yes. So thank you, Dr. Pradeep, for those kind words. And really, it is a pleasure to be amongst all, and especially Kalpana here. So next slide, please. Shrutika, can you change once I start talking, and then, okay?
Sure, ma'am.
Yeah. Thank you very much. And this is just what we know how the magnesium sulfate is used in various diseases. So, in obstetrics, we all know its role in eclampsia. The most common indication is eclampsia. The second one is preterm labor, and third one is fetal neuroprotection. So we all preterm labor, which is progressive survival, and also it is important, which are used just to delay the active phase of labor for at least 48 hours for just taking the in utero transfer or our steroids to act. So magnesium sulfate, which is and then various prostaglandin inhibitors, calcium channel blockers, and nitric oxide releasing drugs, they have shown benefit in these women. We rarely use magnesium sulfate as tocolytics, but it is one of the major, so many studies are available. Magnesium sulfate as a tocolytics. So magnesium labor is very well established, and the first report about the magnesium sulfate as a tocolytic was published in 90 literature, that is in 1983. The outcome of 355 patients who were treated with magnesium sulfate were reported, and these patients had multiple other morbidities such as amnionitis, placental abruption, premature rupture of membranes, or advanced cervical dilatation. Am I audible?
Ma'am, your voice is breaking.
Hello?
Can you keep your video off for some time?
Yes, I have made my video.
Yes, ma'am, please go ahead.
We were defining about the preterm labor and no. What is preterm labor and the use of magnesium sulfate. Can you move the slides, Shrutika? Yes. So the first report about the magnesium sulfate as a tocolytic agent was published in 1977, and it was the largest case series in the literature in 1983. The outcome of 355 patients who were treated with magnesium sulfate were reported, and these patients had other comorbidities as not comorbidities. They had a morbidity such as amnionitis, placental abruption, and premature rupture of membranes or advanced cervical dilatation. And in singleton gestation with intact membrane, they found out that what was the outcome was 76% gained 48 hours before delivery, 51% gained 7 days, and 39% achieved full-term delivery. Next slide, please. Yes. So there are various clinical trials where the magnesium sulfate was compared with the placebo, and in this study, which was aimed to investigate the effect of magnesium sulfate on delay in reaching active phase of labor in women with premature rupture of membranes and subsequent fetal complications, 92 women with PRM were taken up, and in interventional group, 4 grams of magnesium sulfate was given administered over 20 minutes, 2 grams was given per hour which was also given by infusion, and this was continued for 24 hours and after cessation of uterine contractions. The placebo did not receive, group did not receive anything, but just they were observed, and these both groups received a corticosteroid, 1 gram of oral azithromycin and ampicillin 2 gram intravenously every 6 hours for 48 hours, followed by amoxicillin, which was 500 milligram orally 3 times a day for additional 5 days. So these were given, and then the outcome was studies, that is magnesium sulfate caused a delay in delivery for at least 48 hours. Also, magnesium sulfate increased this period 2.7 times the same as in control group. At gestational age less than 30 weeks, magnesium sulfate led to a delay in 77% of women, 87.7% at 30 to 31 weeks, and 72.7% at 32 to 33 weeks of gestational age. So this was there was an average latency in the active phase when the magnesium sulfate was considered. Next slide, please. So the chance of respiratory distress syndrome in infants who had received magnesium sulfate was 80%, less than those who had received placebo, and there was no case of chorioamnionitis or adverse effects which was reported. The conclusion was magnesium sulfate delays the active phase of labor in mothers with PROM and prevents adverse birth outcomes. Magnesium sulfate also was compared with the nifedipine, where 192 women in active preterm labor at 24 to 33 weeks of gestation were studied, and all patients received betamethasone and antibiotics. In interventional group, the 4 gram bolus dose was given by maintenance and followed by the maintenance dose of 1 gram per hour. And these patients were allowed additional 2 gram of magnesium sulfate by physicians, the boluses as needed, and to increase the infusion rate up to 4 gram per hour. In nifedipine group, they had given 10 milligrams sublingually every 20 minutes for 3 doses total, followed by 20 milligram orally every 4 to 6 hours based on physician judgment. The primary outcomes was arrest of preterm labor, defined as prevention of delivery for 48 hours with uterine quiescence. The result was results were judged, and the arrest of preterm labor in magnesium sulfate group was observed up to 87%, nifedipine group around 72%. So all other parameters like gestational age at delivery at in 48 hours, and neonatal outcome were similar between two groups. The patients who received magnesium sulfate achieved the primary outcome more frequently. So magnesium sulfate inhibits uterine contractions, delays delivery by delaying the active phase of labor, it arrests the preterm labor, and significantly reduces the incidence of respiratory distress syndrome. But hardly we use magnesium sulfate as an tocolytics, because better tocolytics are available with us. Issues with prematurity. So what are the issues with the prematurity when we talk of the role of magnesium sulfate in preterm births? The preterm babies are babies who are born before term. They have got many morbidities and mortalities. They have got many other problems like respiratory distress syndromes other than the neural problems. And those who survive, they have neurological impairments, include cerebral palsy, cognitive dysfunction, what we call it is a motor dysfunction, educational difficulties as well, and even psychiatric disorders in adulthood with increased educational and social cost. So role of magnesium sulfate when we decide here, when we talk of neurological impairments, there are pathologically two neurological injuries. One is intraventricular hemorrhage, and usually which is diagnosed by ultrasound. Second one is white matter injury, usually diagnosed by MRI. Clinically, most frequent adverse CNS outcomes, one is cerebral palsy, cognitive impairment, blindness, deafness, and developmental delay. Yes. So when we talk of cerebral palsy, which affects the movement, muscle tone, motor skill, and its prevalence is 1.5 to more than 4 per 1,000 live births or children of a defined age range. It increases due to increased survival of premature infant, of course, but there are various causes other than the asphyxia. We can so many causes are there for cerebral palsy, not only one. So ultimate outcome, what we do is perinatal deaths, and the neuronal outcome, what we always aim at, outcome we aim at. Next slide, please. So magnesium sulfate for neuroprotection, there are multiple mechanisms. One is there is a non-competitive antagonist of glutamate, NMDA receptor. There is increased extracellular magnesium, which blocks the calcium influx into the cell. It blocks the neuronal injury. It stabilizes the membranes, increase cerebral blood flow, prevention of large blood pressure fluctuations, reduction in pro-inflammatory cytokines, and of course, it has got some antioxidant effects. By these methods, magnesium sulfate acts and gives some neuroprotection in the neonates. Although the maternal administration of magnesium sulfate has not been associated with decreased risk of fetal brain injuries as such that are believed to cause cerebral palsy. As I told, there are various causes of cerebral palsy, like severe intraventricular hemorrhage or cystic white matter injury. They have postulated, and it has been associated with the reduction in cerebellar hemorrhage in preterm infants. Next slide, please. So there are various evidence of efficacy from various randomized trials and meta-analysis. And always we talk of these evidence of neuroprotective effects of magnesium sulfate, which is based on data from randomized trials and meta-analysis of these trials. There is significant heterogeneity among these 3 major trials, which are designed specifically to assess the neuroprotective benefits of magnesium sulfate. First one is Australia-Asian collaborative trial of magnesium sulfate, that is magnesium sulfate. And the second one is a famous BEAM trial, that is beneficial effect of antenatal magnesium sulfate trial. And third one is a PREMAC trial, that is prenatal magnesium sulfate trial. And it is very important to emphasize that these combined outcome of cerebral palsy or death is important methodologically, as cerebral palsy and death are competing outcomes, that is death precludes subsequent diagnosis of cerebral palsy. So many they have done, and this is just, I have put it in the graph from up to date, that these are the main 3 trials we always talk of. Of course, we will be discussing these trials in the further we can talk of these trials, but it has got a different heterogeneity, as it was commented. The number of subjects also differ. In acto magnesium sulfate, that is around 1,000, and BEAM trial, it includes 2,241, PREMAC around 572. The dosage also in BEAM trial, they have taken around 6 grams, including the dose followed by 2 grams per hour for maximum of only 12 hours. Whereas in the first trial, that is Australian-Asian magnesium sulfate trial, that is they have given only 4 grams. So they have, we cannot have, there is a heterogeneity of these trials. We will discuss this one by one. Next slide, please. This is just a etiology, how this neurological deficit can occur. Prenatally, any infections like rubella or cytomegalo infections, or whenever there is asphyxia or hypoxia to the brain. Second one is a perinatal, any birth defects, preterm birth, intrauterine growth restriction, as Dr. Mala has pointed out. Then sentinel events and multiple pregnancy. In postnatal, any trauma or any cerebral infections. Next slide, please. So then we are talking about the guidelines and recommendations. So there are so many guidelines, FIGO guidelines, and these FIGO guidelines are the good practice recommendation we all know, and it is a collaborative outcome of various guidelines they take. And so what they advise is women at risk of early preterm imminent birth from viability to 30 weeks of gestation, the use of magnesium sulfate for neuroprotection of the fetus is recommended. So in pregnancy below 32 to 34 weeks of gestation, the use of magnesium sulfate for neuroprotection of the fetus should be considered, and magnesium sulfate should be administered regardless of the cause of preterm birth. This is very important, and the number of babies in utero. So multiple pregnancy also you have to give. When the birth is planned, the magnesium sulfate should commence as close as possible to 4 hours before birth. If delivery is planned or expected to occur sooner than 4 hours, even then magnesium sulfate should be administered, as there is still likely to be an advantage from administration within this time. The optimal regime of magnesium sulfate for fetal neuroprotection is an intravenous loading dose of 4 grams that is administered slowly over 20 to 30 minutes, followed by 1 gram per hour maintenance dose. And this regimen should continue until birth, but should be stopped after 24 hours if undelivered. Next slide, please. Then comes the ACOG. ACOG also recommends that magnesium sulfate reduces definitely the risk of cerebral palsy, and it has also taken account of various available evidences. And they also say that it should be given before anticipated early preterm delivery, which also they have endorsed that it reduces the risk of cerebral palsy. Next slide, please. Now, this is recommendation again for the neuroprotection of magnesium sulfate. Various authorities also have endorsed the role of magnesium sulfate. So they have endorsed that. They also tell that the fetal indication for delivery at 23, that is a lower limit of viability, 23 to 31 plus 6 weeks of gestation, they should receive magnesium sulfate. So exclusion is, of course, when you cannot give magnesium sulfate, we all know. I have already put it. That is evidence of renal insufficiency, myasthenia gravis. It is, of course, the magnesium sulfate is contraindicated. We all know that. Next slide, please. WHO recommendations also it is a strong recommendation that magnesium sulfate should be given whenever there is an imminent preterm birth before 32 weeks of gestation for prevention of cerebral palsy in infant and child. And these also they have endorsed for singleton and from the Australia, New Zealand, Canada, Ireland, Belgium, United Kingdom, FIGO, WHO, France, and USA. You can say that they have given loading dosage 4 grams and early, and only France and they have not specified this WHO, but 4 gram is the least starting loading dose for all the recommendations. Only thing is, you can see here, WHO stops at 12 hours as well as France recommendations. These are up to 12 hours. So whatever the loading dose remains the same, that is 4 grams followed by 1 gram per hour until birth, and not more than 24 hours. That's what is we following the whatever guidelines we follow here. Next slide, please. Now, as I told, the contraindications and precautions we have to take whenever we are giving magnesium sulfate. The major contraindication is a myasthenia gravis, since it can precipitate the severe myasthenic crisis. Myocardial compromise or cardiac conduction defects we should not give, because it is anti-inotropic effects, and impaired renal function, which is defined as serum creatinine greater than 1 milligram per deciliter, as magnesium is eliminated by kidneys. So we have to maintain the proper GFR, that is 30 ml per hour or 100 ml per hour per 4 hours. So that has to be maintained, and we have to monitor the magnesium sulfate whenever we are giving we have to see for the patellar reflex, as we do in eclampsia. The same protocol we follow whenever the magnesium sulfate is also given whenever we are giving for the neuroprotection. Next slide, please. Yeah, there are n number of clinical trials they have done with the magnesium sulfate, and they discuss about the magnesium sulfate and their effects on outcomes. Next slide, please. So in India, they have studied the efficacy of antenatal magnesium sulfate neuroprotection in extreme prematurity. Comparative observational study, the 100 pregnant women who had preterm birth. In interventional group, as the routine, our loading dose 4 grams, followed by they have given loading dose of 4 gram in 100 ml of normal saline over 30 minutes, and preferably 4 hours prior to preterm birth. And maintenance dose was not administered in these patients. In control group, no magnesium sulfate was given. And what was the outcome they studied was the adverse clinical outcome in magnesium sulfate and control group. The result was the infants who received magnesium sulfate were less likely to require invasive mechanical ventilation compared to the control group, and magnesium sulfate had a protective effect on the need of invasive ventilation in preterm infants. Neonates with antenatal exposure of magnesium sulfate had more days free of respiratory support in the first 28 days. So these are the important things they have observed in this trial, this clinical trial. Next slide, please. This is another trial where it was a prospective randomized control trial where 50 pregnant women who had a preterm birth, where 4 gram loading dose was given. And again, here there was no maintenance dose was not given. And this study was conducted in medical college in the last year. And the inclusion criteria was all pregnant women of gestational age 28 to 34 weeks of labor who would deliver in next 24 hours. So the next maintenance dose was not given, only that first loading dose was given. Next slide, please. And the result was the Thomson score, which revealed that the 60% of the newborn had a normal neuronal development, whereas 38% had a mild and 2% had a moderate neuronal abnormalities. The infusion delivery interval which was done was 80% deliveries occurred after 13 hours. So this was a outcome which was studied about the neuronal development. Next slide, please. Even they studied of the APGAR score, and the APGAR score was 1 minute. At 1 minute was 5.78 at 5 minutes, and at 5 minutes it was 7.44, and 92% of the neonates were normal. So magnesium sulfate, which was given for the fetal neuroprotection before preterm birth, avoids cerebral palsy and lowers the combined risk of fetal and infant death or cerebral palsy. Significant neuroprotective advantage to the neonate, and it is safe drug to use in antenatal women. That was the conclusion. Next slide, please. Yes. So there was a trend towards reduced risk of in the magnesium sulfate group for intraventricular hemorrhage and neonatal hypotension, hypothermia, length of NICU stay. Intraventricular hemorrhage was less frequent and less severe in babies exposed to antenatal magnesium sulfate over control. So the conclusion is, again, the magnesium sulfate is a safe drug. We can use in antenatal women at risk for impending preterm. Antenatal magnesium sulfate confers significant neuroprotective advantage to the neonate, and it is time to start using magnesium sulfate in our clinical practice for neuroprotective intent in all our extreme preterm birth. Next slide, please. So this is another large trial, comparatively the earlier trial, where they studied around 1,000 plus women, 1,062 women with fetuses younger than 30 weeks of gestation for whom birth was planned or expected within 24 hours were enrolled. Here they gave 4-gram loading dose, and then followed by a maintenance infusion of 2 grams per hour for up to 24 hours. In control group, isotonic sodium chloride solution was given, and the rates of total pediatric mortality, cerebral palsy, and the combined outcome of death or cerebral palsy at a corrected age of 2 years they studied. Next slide, please. So the result was in magnesium sulfate group, the total pediatric mortality, cerebral palsy in survivors, combined death or cerebral palsy, gross motor dysfunction, combined death or substantial gross motor dysfunction or pretty less. So you can see here the figures as well. And the magnesium sulfate given to a woman immediately before very preterm birth may improve the important pediatric outcomes. No serious harmful effects were seen in this group. Next slide, please. And this is our PREMAC trial, which is mentioned. That is effect of magnesium sulfate on mortality and neurological morbidity in very preterm newborn with 2-year neurological outcome, which is again a RCT, where 573 women less than 33 weeks whose birth was planned or expected within 24 hours. So here the interventional group received a single injection of 0.1 milligram per liter magnesium sulfate, that 4 gram over 30 minutes. In control group, they have given isotonic sodium chloride solution. And the result they studied was the decrease in all primary endpoints like total mortality, severe white matter injury, and their combined outcome, and of all secondary endpoints, that is motor dysfunction, cerebral palsy, cognitive dysfunction, and their combined outcome at 2 years of age in the magnesium sulfate group. Next slide, please. The decrease was significant for gross motor dysfunction and combined criteria, that was death and cerebral palsy, death and gross motor dysfunction, death and cerebral palsy, and cognitive dysfunction. So given its beneficial effect and safety for the use for prenatal low dose magnesium sulfate for preventing neurodisabilities of very preterm infants should also be discussed, either standalone treatment or as a part of combination treatment, at least in the context of clinical trial. So this very low preterm, we need to counsel the patient because we have to see the outcome as well. Next slide, please. So there are again meta-analysis of various 5 RCTs with 5,235 patients. The effect of antenatal exposure to magnesium sulfate on neuroprotection and mortality in the preterm infant, this is a meta-analysis. They concluded that fetal exposure to the magnesium sulfate in women at risk for preterm delivery significantly reduces the risk of cerebral palsy without increasing the risk of death. Next slide, please. So the Cochrane review. This Cochrane review, which is published in 2009, also endorses that it has magnesium sulfate reduces the risk of cerebral palsy in the child, and the substantial gross motor dysfunction, and definitely at the 2 even that is motor dysfunction. How they study is inability to walk without assistant at 2 years of age. So magnesium sulfate had no significant effect on pediatric mortality. That was the outcome which was published Cochrane review. The number of women needed to be treated is around 63. Next slide, please. These are the Canadian guidelines, that is ACOG clinical guidelines, that is for women with imminent preterm birth, less than 31 plus 6 weeks, antenatal magnesium sulfate administration should be considered for fetal neuroprotection. Then what is imminent preterm birth? That is defined as high likelihood of birth due to one or both of the following conditions, that is active labor, more than 4 centimeters of cervical dilation, with or without PPROM, and planned preterm birth for fetal or maternal indications. Next slide, please. So in summary and recommendation, in pregnancies at high risk of preterm birth, within 24 hours, administration of magnesium sulfate is recommended. In utero, exposure to magnesium sulfate before early preterm birth reduces the incidence of cerebral palsy and severe motor dysfunction of offspring. Then upper and lower gestational age to define is very important. Limit magnesium sulfate therapy for neuroprotection to pregnancies that have reached a gestational age at which mother opts for a neonatal interventions, but are less than 32 weeks of gestation. Next slide, please. Emergency delivery. If the emergency delivery is necessary, it should not be delayed to administer magnesium sulfate. Now, what about the retreatment? If the patient does not give to birth after an initial course of magnesium sulfate therapy, we suggest not to retreat. This is a grade 2C recommendations. And tocolysis, if you want to do tocolysis, which is indicated because of preterm labor, the most effective agent with the most favorable side effect profile should be chosen. And we recommend endomethacin. Whatever the guidelines say, but endomethacin is a preferred because whenever we combine nifedipine as well as magnesium sulfate, we know the side effects. So the endomethacin is a preferred tocolytic agent. Antenatal corticosteroid, a course of antenatal corticosteroid should also be administered according to the standard guidelines. So this is what I feel that should be summarized, and it is recommended in women at risk of every preterm birth, significantly reduces the adverse clinical outcomes, and also reduces the pediatric mortality, cerebral palsy incidence. Next slide, please. So, despite the clear benefit of magnesium sulfate, despite the well-established superiority of the magnesium sulfate management of the severe preeclampsia, eclampsia, and preterm labor, it continues to be used suboptimally in India. And there are various solutions nowadays. We all know Lissons have come with the 4 gram solution in 100 ml. So it is very easy to use and monitor also. I just have to have some comments from others also. How many of us really use magnesium sulfate for neuroprotection? We have to publish another larger trials about this. And most, I have some doubts about the lower and upper gestational age. No doubt they say about the lower limit. For the patient, for the lower limit of viability is still to define, and peri-viable, what we call it as a peri-viable birth, that is a limit of viability still to define, because we have to confer and we have to discuss with the neonatology team, and jointly we should counsel the mother also about the possible management strategies whenever we define about the lower limit, when we can salvage these infants and then administer neonates and administer the magnesium sulfate for the neuroprotection. So none of the randomized control trials of the magnesium sulfate for neuroprotection included the pregnancies at less than 24 weeks of gestation. Although all the prospective observational studies, they have included the pregnancy as early as 22 weeks onwards. And the upper limit I wanted to comment on is we limit the use means between less than 32 weeks, because majority of the data of our randomized control trial are derived from the pregnancies of less than 32 weeks. There are no trials of 30 or term or 32 weeks because there are no data and there is no value. The potential value of the magnesium sulfate at term infants is unknown. I don't know about the studies in India because I did not find much time to study those. But what in our practice by Dr. Pradeep, and it is really interesting. And the retreat, many people have commented, and you should not see, you have given the magnesium sulfate and the patient has not gone in labor and these are my whatever the views on this topic. Thank you very much, Dr. Pratik, to bring in
Thank you, Dr. Vidhya Thobbi, ma'am, for an elaborate and exhaustive presentation on magnesium sulfate.
Me and really it is a thought-provoking topic about me.
Yeah, thank you again, Dr. Vidhya Thobbi, for being here and for explaining to us in elaborate detail about fetal neuroprotection. I see Dr. Kalpana is here. Ma'am, any closing remarks on this talk?
Yeah, that was a wonderful deliberation as usual by you, ma'am. It was really useful for all the delegates who had joined in huge numbers, mainly because of the efforts by Pradeep sir. Thank you, ma'am. Even though we couldn't meet you personally, physically, at least we had a chance to meet virtually the day before the great conference. Thank you, ma'am.
Thank you, Dr. Kalpana. If Dr. Lakshmi Madam is here, any closing remarks from her, Dr. Mala? I see that there are some questions in the chat box, but most of them have already been addressed by both the speakers. There was one question regarding how we can prevent fetal growth restriction from happening. So that was covered in elaborate detail by Dr. Mala. We also have a couple of questions regarding carbetocin, but I think that's not relevant to today's talks. We will probably address that in a different program. I'm very happy to announce that we have fantastic attendance for today's event. We've crossed 1,400 delegates, which is amazing. It speaks volumes for the quality of our speakers as well as the topics. The topics actually are something which are of practical and clinical significance. I've just been given an update. It's now 1,759 exactly. So that's something which is unprecedented. We used to see those kind of volumes only during the pandemic. During COVID, we used to see those kind of attendances. So that's amazing. And thank you so much, everybody, for being here with us. If there are any closing remarks, I would request the speakers to please speak. Otherwise, I will propose the formal vote. Dr. Vidhya Thobbi, ma'am. I think she's facing some internet issues.
Yeah. Internet is slow.
Yes, Dr. Pratik, I must congratulate. Hello.
Yes, ma'am, please go.
Hello, am I audible?
You're audible, ma'am.
Yes.
Yes.
must congratulate Dr. Pratik only to bring in such a new things and new topics, and they're for debate. Really, I feel so, and thank you again for bringing me and calling me. I appeal all the ICOG fellows who have joined here to vote for me as well as Dr. Pratik. We are again contesting for the ICOG Governing Council member this year. Thank you very much.
I see Dr. Mala has taken time out from the OT. She is back with us. Ma'am, please
Yes,
unmute.
she was in
Any
OT.
closing
Yes.
remarks? Yes,
Hello.
Dr. Mala. Yes, ma'am, we can
Yeah,
hear you. Please
it
go
was
ahead.
really a great session and really thoroughly enjoyed today's session with Dr. Vidhya Thobbi going into great details of tackling the neuroprotection with MagSelf and how it can impact the neurocognition and neurodevelopment of the growth restricted fetuses and how important it is. Thanks, Dr. Vidhya, for that excellent scientific deliberation.
Thank you, Dr. Mala, for being with us. Dr. Kalpana, any closing remarks before we close the session?
It was wonderful talks by great speakers, and it is so unique that two are going for ICOG chairs election and two are going for chairperson election. So thank you, sir, for the wonderful opportunity.
Thank you, Dr. Kalpana. I think at the end of the day, I need to place on record my gratitude to our backbone, Science Integra, Subhu, Shrutika, who is here today, the entire backend team. I will not be able to name each and every single person. But thank you for putting together such wonderful academic events for all of us, especially in this experience series. Today we had the theme of the fetus in focus. We had two fantastic chairpersons. Our chairperson of ICOG, Dr. Lakshmi Srikhande, graced the occasion. She was here for quite some time. Dr. Kalpana is joining us despite being very busy organizing the Yuva Foxy. We'll see her in person in a day or two. Thank you so much for being here. Two fantastic talks by Dr. Mala Srivastav on delivery considerations in fetal growth restriction and Dr. Vidhya Thobbi on fetal neuroprotection. I must also place on record my gratitude to all the delegates. I see Dr. Lakshmi is joined in. Yes, ma'am.
Pratik, am I
Yes, ma'am.
audible?
Yes, you're audible. I was just
Voice is-
presenting the vote of thanks. So
No,
thank
I
you for
just
coming
heard.
in time.
But is my voice clearly audible?
Yes,
Because
ma'am.
when
Very
I
clear.
logged in, it
Loud
was
and
not
clear.
loud and clear.
Loud and clear.
Yeah.
Yes.
So as usual, it was a very informative webinar and a very focused webinar, Pratik, and very informative and useful for all the delegates. So keep doing such focused webinars, and we all are there with you. Thank you,
Thank you,
Pratik.
ma'am. Madam, 1,759 attendance today.
Great.
So I must also
Great.
place on record my gratitude to Glisten, who are our academic partners in this series. They've been doing events with us for the past year or two. They are the makers of IV Mag, which is magnesium sulfate, which we tackled today. Injection I3, which is iron isomaltoside, a newer variant of parenteral iron, which you've heard other speakers talk about at other events. And of course, Carbacin, which is their own version of heat stable, room temperature stable carbetocin, which has revolutionized the management prophylaxis of PPH. So thank you everybody who logged in. We hope to see you at the next event. Until next time, goodbye, God bless, and thank you very much.